Welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Miguel Quiñones, the editor-in-chief of the journal. And as many of you know, the journal publishes issues dedicated to reviewing specific medical topics in cardiovascular medicine and surgery. This time we're doing it a little bit differently. This current issue actually was proposed by the guest editors that I will be introducing in a second. And we have been privileged to be very much involved with that technology here at Houston Methodist. And we thought that it was a good idea to have an issue that summarizes the state of the art in terms of applying this technology specifically in surgery. And even at the end, talk a little bit about some of the future developments that could really improve the way we operate during surgery. So without any further delay, it's my pleasure to introduce Dr. Alan Blonsden, who does not need much introduction. Alan is the Walter Fondren Distinguished Endowed Chair in Cardiovascular Medicine. He's also the medical director of our heart center and an excellent cardiovascular surgeon. And joining him is Stuart Kaur, who is Director of Innovative Engineering at the Bookhouse Center here at the Methodist DeBakey Heart and Vascular Center. So without any delay, Alan, take it on and tell us all about this wonderful technology that is coming on.
Well, thank you, Dr. Quiñones. And let me say that I became the medical director and followed Dr. Quiñones. And so those were always big shoes to follow. And as editor-in-chief, thank you for taking a chance on us, okay? This is not what we'd call traditional cardiovascular stuff. This is certainly trying to look over the horizon at something that we've become very interested in. So robotics in surgery. You're an imager, and we have a powerhouse of imaging group, which you were largely responsible for building along with Dr. Zogby. And I've always said that, imaging in terms of doing interventions can take you to this level. Robotics can take you to this level. But when we bring them together, it's going to allow you to do things that otherwise really can't be done. Yeah. And the platform that allows you to do that is the intelligent part of this title. Some would say digital. I am unfortunately old enough to remember taking a chest x-ray, putting it up on the wall, looking for a viewing box. And the big change that took place was suddenly it became digital. And you could see it on a computer monitor. That is such a big leap. And so what now happens is if you take a CAT scan I think of as a patient's universe. They're all on that CAT scan. And if you can take that CAT scan and now stick it and fuse it on top of a patient in a room, an operating room, or an interventional suite or cath lab, you can draw lines on it, and those lines could be what I call pathways for a robot to follow. Whether it's an endovascular robot, which is a catheter that sneaks up inside the blood vessels, or whether it's a surgical robot, Intuitive or the big players in that, it all depends upon the ability to digitize those images and make it portable to where we are actually going to intervene on the patient. And so one of the other aspects of this is that it's all math. Now, I'm not a mathematician, but this is all math. And so everything that's done with a robot, every movement that takes place with a robot is measurable. So you could come to me and say, hey, is that a good surgeon? Who does things open. You have to kind of stand and peer over the shoulder for half an hour and see if you can figure out if they know what they're doing. Everything's measurable in the robots. And so, and that, for good or bad, basically gives enormous power to these robotics companies. They know exactly who's a good surgeon. They know, and so, for example, in general surgery, you can't train on these new robots without that data being stored for every case that you do. Stored by the robotics companies. And this is all being used to reinforce the learning pathways that are involved in these robots. So to say it's intelligent is probably an understatement of the year. Stuart came up basically with that idea. And so one of the things we are interested in is, because I think vascular surgery has kind of missed the boat a little bit. We've seen the general surgeons take off in terms of doing robotics. Now in this organization, we have kidney transplants. Well, last time I checked, kidney transplant was sewing an artery to an artery, sewing a vein to a vein.
I have a 28-year-old grandson. Mm-hmm. When he was 14, he had a repair of a congenital lesion in his kidney through a robot.
Yeah.
So that was 14 years ago. Here at Methodist, by the way.
Yeah, I mean, so ablative stuff and reconstructive stuff have taken a long time. What has limited the vascular world is fear of bleeding and uncontrollable bleeding. And so that's one of the reasons that we kind of embarked upon trying to build a vascular robotics program. And along with this, and Stuart can talk a little bit more about this, building the Bookout Center. And it's probably worthwhile talking about that. And then we'll start introducing the various different speakers that we've got online. So thank you for taking a chance on us. I hope people actually look at this journal.
Cool. Yeah, so just to go on to that, for those of you who don't know what the Bookout Center is, it's a 35,000 square foot facility dedicated to advancing intelligent surgery. Right? So what is this kind of concept, intelligent surgery? We see it as the fusion of advanced technologies, of data, and then the human expertise. That's the real sweet spot here. It's the place where surgeons, residents, trainees go to learn. It's where they are exposed to new types of technology. You know, maybe they want to research using that tech. Maybe they want to innovate using that tech. So we make that easy for them. You go along, you interact with technology, you learn something, and perhaps it's good for you with your practice. The other side to this is tech development and research. You know, there's a lot of problems that we encounter on a day-to-day basis that perhaps there is no solution for, either externally or coming to market. So if that's the case, then we want to pioneer that solution. We want to actually create that in-house, maybe even license that out to some of the heavy hitters out there, etc. We're about 18 months into this, and there's a few interesting things just coming on the horizon, which we'll let everyone know next year. But to conclude this, all the papers in here, it's really a snapshot of how vascular and cardiovascular surgery plays into the Bookout Center. I mean, the Bookout Center is a resource for the entire system at Methodist, so all specialities. But we've used this as an opportunity to highlight what we've been doing in the cardiovascular space. So I really hope you'll kind of get some enjoyment out there and use this as a primer to maybe get things going on your side.
All right, so we introduce our first guest. Yep. So a privilege falls to me to introduce one of our integrated vascular resident. Integrated means that you come straight into vascular surgery training from medical school, as opposed to do 5 years of general surgery and then fellowship. So that's why he's so young looking. And so Jacob kind of spent a year with us, and he's going to talk a little bit about from data to decision, a comprehensive review of real-time analytics and smart technologies in the surgical suite. Jacob.
Hey, good afternoon, everyone. Thanks for having me. I'm here to discuss our paper, like Dr. Lumsden said, from data to decision. And the goal of this work is to explore how data, which is already being generated in every operating room, can be captured, synchronized, and analyzed in real time to provide improved safety, precision, and efficiency in surgery.
All right, so questions. Give us an example of smart technology.
Yeah, so a smart technology would be something like a few emerging technologies that could make a big impact would be something like taking artificial intelligence applied to surgical video. Every robotic or laparoscopic operation generates hours of high-definition video, and these AI systems can now analyze those feeds in real time. They can recognize what step of the procedure we're in, what instruments are in use, and whether anything looks abnormal. Some of the companies we referenced in our paper, like Care Syntax and Surgical Safety Technologies, are developing AI that can detect events such as a vascular injury or a skipped safety check in common procedures and alert the team right away. It's kind of like having a digital surgical assistant that's always paying attention. Another company that is in our paper and that we actually had at our robotic summit earlier last month is Methodist, and that's on the topic of augmented reality navigation. They're working on projecting patients' preoperative imaging like CT or MRI onto the surgical field, giving the surgeon kind of X-ray vision where you can literally see arteries, tumors, spine hardware. And really the challenge there is optimizing image registration. That's a big area that we're all working on and trying to improve for the future. But it's already being used in neurosurgery and spine surgery where precision down to a few millimeters can make or break an outcome. So those are two really exciting areas that we touch on in our paper.
So again, for the broader audience, if we can take a CAT scan that you had a month ago, and you've been given dye, we can see all your blood vessels. and we can fuse that image on top of you lying on the operating room table, then we don't need to give you any more dye because all the blood vessels and things are already outlined. But the fusion's got to be accurate.
Yes.
So fusion is really important. And there's a couple of ways of doing that. One is to use modern day angiographic suites. People say to me, hey, you want another angio suite, Dr. Lum? I said, no, I've had an angio suite for 20 years. We're buying a CAT scanner. These machines can create a CAT scan. And so that allows us to make a quick and dirty CAT scan of you in the operating room and then bring in the previous images and fuse them. And then we can basically start drawing these center lines, which potentially are glide paths for the robot. So that's one example really of how this can be done. It could also be done for open surgery by surface scanning. I always say to people, never get a CAT scan in the hospital you're working in. Because you're on that CAT scan. You and all your glory are on that CAT scan. And if we window it, just like you can work in Photoshop, you're on it. And so if we can see the surface, the scan, your belly button, everything else that we can potentially fuse with, and you can bring these surface rendered images together, then that's another way of creating fusion. So fusion is rapidly moving in interventional suites and in operating rooms.
So when you talk about facilitating to the robot, once you have that information, what is the robot doing? Passing a catheter, cutting something?
So
for the purpose of the audience, exactly as a surgeon, what would you do with the robot? Would you be using robotic surgery like it has been done now for several years, or will you be passing a catheter somewhere?
So two different development pathways. Okay, so this institution is probably the international lead on catheter robotics.
Mm-hmm.
That happened because your partner, Dr. Valderrama,
yes,
was using it to do left atrial appendage ablation. And I went to watch him. And this is the advantage of watching somebody other specialty. He had a catheter in the left atrium, a beating heart, and said, I want to move it 3 millimeters to the left and apply a known amount of pressure to the wall because you can perforate the left atrium. That kind of control is unheard of. You can't do it any other way. And so that kind of got us into catheter robotics. We were the lead center in getting the FDA approval for it. And then they sold it to a company called Auris. Auris converted it into an endobronchial robot. It's exactly the same. And to quote some of the oil and gas guys that we work with here, it's all about working through long, thin tubes. The technology is the same. And they saw a much more rapidly developmental pathway in the bronchus than inside the blood vessels. They sold that company to J&J as an endobronchial robot 4 years later for $4 billion. And is now the Monarch robot with J&J. That then led to Intuitive developing the Ion. So the endobronchial robotics spun out of endovascular robotics. And the advantage is that everything that's being learned about image fusion to do exactly what we've talked about. CT scan shows a lung nodule. You get basically a quick and dirty scan in the operating room, fuse these images together. You can see the bronchi and you draw a path for the robot to go in your bronchus. And they can get further out with the robot to biopsy the lung nodule. And some people go, well, you're a vascular surgeon. What about, why do you want to look at lung nodules? Because everything that's being learned at the moment is going to come back into the cardiovascular space. So that's, the catheter robots have kind of stalled, although they're starting to come back again. And a lot of the development is taking place in and around us, but it's going to happen as opposed to surgical robots. Okay, Jacob, and not Jason. I never know any of the residents' names. I get in trouble with them. If hospitals want to start using more real-time data in surgery, what are they going to do? What's the first step that they can do?
The first step isn't going to be buying more equipment. It's going to be connecting what's already there. Most hospitals already have the necessary technology. It's going to be monitors, imaging systems, robotic consoles. The problem is that these systems don't communicate. So the first practical move is to build an interoperability, making sure data from every device can flow into a common framework. So standards like HL7 and DICOM already exist for this purpose, but they're not consistently applied in the operating room. Something as simple as time synchronizing all your devices can transform how data is analyzed, to be able to link events in the operating room across different, whatever point in time, say this is what was happening at the head of the table with anesthesia versus with the circulator nurse versus on the table. The second step is going to be to start small with a focused pilot project, pick one use case, say integrating surgical video with vital signs. and measure whether it improves safety or efficiency. That single proof of concept can build credibility and make it easier to scale across departments. Third, I would say, is to build a data culture. Technology alone doesn't make the operating room smart, people do. The entire team needs to be trained to interpret, trust, and act on the data. So the roadmap I would project would be connecting your systems, proving the concept, and training your people.
Well, what's the minimal amount of technology that that hospital would have to purchase just to get going with what you have suggested?
I would say everything you already have for hemodynamic monitoring, the instrument tracking. If you can integrate some kind of third-party camera with a global view, as well as a surgical feed. And the big thing is going to be the time synchronization, where you can link events across multiple locations on a time scale.
So for example, some of the things that we've got here, so I get notified, this is about to hit the cath lab, they're not going to like this. They have cameras in the walls which track all motion inside the room. And so we get automatically notified when the patient rolls in. This thing's called a Pella. And that's a time point that is documented. We get told when the patient is draped, and that means they're covered in blue. And that means get your butt over here because you have 10 minutes to get started. And then we get told when the patient leaves. And there's a whole bunch of other things, but it's real time tracking everything that's going on in that room.
That alone should improve efficiency like crazy.
Okay,
Yes.
hopefully well. But along came Siemens now have a robotic portable C-arm.
Yeah.
And it can drive in, and you can say, store that position, drive back out. It goes parts itself. And then say, okay, we're ready, it's got to come back in. But the problem is, the room is dynamic. And so maybe the nurse puts the electric artery in the path for the robot coming back in. So by linking it up to those cameras, which are real-time monitoring where everything is, can they communicate with the robot to reprogram the path for the robot to come back in? And so this is going to be transformed with all these kind of technologies which are taking place. Okay, Stuart.
All right. Before I introduce Dr. Roy, I just want to say as well that Jacob was really part of a study we had recently in the Department of Cardiovascular Surgery looking at surgical instrument tracking in the clinic. We're really proud that we were one of the first institute nationwide to actually do that study here. And what you're looking at is basically tracking all your tools and your instruments in the OR. And it's never been quantified before. So that was with M&S Biotics. And we actually have a little bit of that in the paper. So please read it to get a little bit of an update.
So you want to give them, the synopsis of this is pretty powerful. First of all, they take the table, which normally just is on the table you stick instruments on. It's an RFID generator, radio frequency field generator. Every instrument has got an RFID tagged on it. And so every time you take it off, it measures it. Tells you you've not left anything in the patient. But much more importantly is that, let's say for an average case for me, you open 200 instruments. Every one of those has got to get cleaned at the end of the day. I may use 25 of them every time. We may use 25 of them 50% of the time. And what these guys showed was 50, over 100 instruments are never used. And so the whole design is, can you make this in a separate pack, have them available in case we need them, but the amount of work that would, because every one of those instruments gets hand inspected, hand cleaned if need be, and then re-sterilized, and it's a completely another waste of time for the majority of it. So it's a pretty simple concept, but it builds into this idea of having a smart operator.
Absolutely correct.
The other thing is 70% of the revenues of this organization are generated in interventional suites and operating rooms. The more efficient we are, the better the institution is.
Yeah. So
there's always a bottom line.
Yeah. All right.
So
speaking of the bottom line,
make note of that one.
Yeah. So I'm very honored to have in the studio a true force of nature, Dr. Tricia Roy, MD, PhD, currently has an R01. There's some absolute exceptional work coming out of Dr. Roy's lab, and she put together a wonderful paper here with her team on MRI and AI integration with deep learning techniques to actually diagnose peripheral vascular disease. So for the audience, in everyday terms, like how are you combining MRI and AI to better understand plaque morphology and to treat that type of plaque?
I think we kind of have to take a step back. So this is all really to do with peripheral artery disease, blockages in the blood vessels of the leg. And we've always treated this like a plumbing problem, but those blockages can be made of very different types of material. You can have something as hard as concrete, and then some things that are really soft. And depending on that, the vast majority of our treatments for this is about unblocking these blood vessels. And we have many different tools to do that with lasers and drills and so on and so forth. But we don't really know what type of tool and what type of treatment is going to be best for an individual patient and their individual blood vessels, because all of our blood vessels are very unique. So, we've been talking a lot about CAT scans. So MRI is something that's very, very powerful as an imaging technique, because depending on how you sequence them, you can draw out different tissue characteristics, okay? So things like, is there intraplaque hemorrhage? Is there inflammation? What's it made out of? Is this dense collagen or calcium? These are things that you can see with an MRI because it's powerful. The flip side of that is, because it's so powerful, you get too much information, right? So you end up having a million different sequences coming at you with different contrasts, and it's very difficult to interpret. And then Dr. Lemson's like, hey, can you find me the one that looks like a CAT scan? And then, want to go from there. So with AI, the whole point is to take that rich data that you'll be able to get with multi-parametric imaging with the MRI, but distill it in a way that's usable. Give you a tissue score, tell you if it's crossable or not, what wires should you use, what's going to be your problem spots, and presenting it in a way that's going to be usable for us.
So just curious, using MRI, but what are you doing with the MRI? Are you using some type of novel conjugated gadolinium or iron oxide, or is it a certain sequence that you're using to get the characteristics out?
So this is all non-contrast methods, which is beautiful. You're using the intrinsic properties of the tissue itself. So most of it is relying on ultra short echo time imaging. Okay, so what that involves is, you give a pulse and then you acquire the image, but you do it very quickly. Before, we couldn't see calcium because the signal decays very quickly. With these newer sequences, it doesn't require any special equipment, doesn't require any contrast, but you can draw out these really important features, which is going to make or break our cases.
So this is software development.
The UTE MRI is a works in progress sequence right now. Yeah.
So AI is fastly or quickly dominating everyone and everything. I mean, you can't go anywhere now without hearing about AI, right? So what's one practical way that AI could help clinicians, surgeons identify those regions?
Well, I think that some of the things that you had talked about already in terms of, fusion imaging, being able to use those roadmaps during your intervention to guide your wires or devices, I think is going to be really important, because right now how we're doing it is we inject contrast and take x-rays and we're completely blind. So that's like a very easy, practical way this can be used today. But what I'm really excited about is what it's going to be used in the future. So we're taking things like the MRI signal behavior of these plaques and relating it to the histology, but also the spatial transcriptomics with Guangyu Wang's lab. And what that tells you is really the gene expression of what we're looking at and the underlying biology. I think that one of the big revolutions in oncology is they stop just whacking out tumors, but looking at the biology that drives that, and that's transformed their entire field. And for us, with MRI, we're able to see these buds of calcium. We're able to map that to some gene expression. And I think that ultimately, our drills and our mechanical means of dealing with this fundamental biologic problem, it requires a different approach. And I think PAD, we're ripe for it.
So the Achilles tendon of interventions in PAD have been the high grade of restenosis, right? So how do you envision all these new developments eventually dealing with that? Because that has been the real
I think
problem with that.
I think that there's different reasons why we're getting restenosis, right? So if you're taking a lead pipe and cracking that open and you get all these dissections, that's going to be something that's going to be just setting yourself up for restenosis. So that kind of vessel, you're wanting to use things that are going to change the compliance of the blood vessel, as an example, so that you can inflate balloons safely without disrupting the vessel wall. That's going to be very different than, chronic total occlusion made of dense collagen. How that behaves where you're going to have problems there is really how to actually open up that blood vessel and get your wire across. Things like radiofrequency ablation can be effective for collagen-based lesions. So depending on what it is, I think that we need to tailor the interventions, and that'll be more durable in the long term.
So as we move forward, the proof of the pudding will be eventually doing some trials where we show that applying these technologies will reduce restenosis and all the other complications.
Yes.
How far do you think we are from doing a trial like that?
Well, Dr.
A year, 2,
Dr.
3, 4,
Kaur
5?
just talked about our
Will it happen
R01.
will it happen before I retire?
Yeah, it's happening now. So no, we're really excited. We got an R01 to do a prospective study in 100 patients using these MR images, characterizing their lesions and tracking those types of outcomes, procedural outcomes, but also restenosis rates and how that is affected. Because you're right, if we don't show any clinical validation, none of this matters, right? And so we are developing that with the support of the NIH.
That's pretty cool.
So I'm going to change the last question a little bit, right? So obviously, if you've gone and characterized this plaque and you're still limited to your toolbox, right? To your set of instruments that you can use to intervene. And I'm sure you've had cases where you're like, I wish there was like other tools. But you've recently launched a new core here at the hospital, right? To allow those tools to get developed quicker. You want to maybe just tell us a little bit about that?
Yeah, this year we launched the Peripheral Vascular Device Core. And so what this is a really unique resource where we take amputated limbs from real patients with real complex disease, and we can characterize all those lesions with the MR images that I was talking about. And then we can use the device of question and see under a microscope when we harvest it, what did the actual device do to the vessel wall? There's nothing like that anywhere. Right now, the FDA approvals and all that is based on healthy animal models, which are not at all reflective of the disease we treat. Then we get all these devices on the market, and then they all get recalled because of some terrible events that can happen with that. So we're working with companies at all different stages, really mature companies who just want to understand their devices better, new startups, and then, with you, we're trying to develop our own devices by understanding why we're failing with the current approach.
All right, Dr. Roy, thank you. Over to Dr. Lumsden.
All right. It's my privilege to introduce Dr. Bavari. Dr. Bavari is one of my partners, and he's the guy who essentially spearheaded the development of our clinical vascular robotics program. So he had his 100th case a month ago. And so the question is, how do you do this? From a clinician standpoint, why should we use robotics? What's the biggest advantage, Charo?
Well, thank you for having me, and thank you for that introduction, Dr. Lumsden. I think we've been ruminating on the fact that endovascular procedures make it easy for us as clinicians and somewhat easy for the patients to recover. But the durability of the endovascular fix is not close to open vascular procedures that we've also been trained to do. And so if you look at a durability of a Dacron graft that Dr. DeBakey devised in this very hospital and sewed into a patient here, has lasted for 10, 15, 20 years. And an endovascular graft put in a few months ago may have had problems today or will have problems in the next few years. So if we can change the delivery system with minimal invasive approach to give a better durable repair to the patient, that's where I think robotics comes in. That's how we can leverage robotics to help vascular surgeons do better inside our patients with a better repair and with a better recovery chances.
Why?
Well, so this is something Sean and I have talked about, is that, our specialty is guilty of, actually led by your specialty, is giving up core efficacy for the sake of a delivery system. Okay? Yeah. I understand the only thing that makes you live longer if you've got coronary artery disease is Lima and LED bypassing, but that hasn't stopped a multi-billion-dollar stent business being developed. In our world, we've done the same thing. We've come, maybe Trisha's going to solve this, but you open up a blood vessel in the superficial femoral artery so you can walk further. It's not supposed to be back to the interventional suite again and again and again. And maybe the things that Trish are doing is going to transform that. That's going to be the ultimate challenge. But what we're interested in with the robotics, if we can go back to maintaining the old-time surgical operations, but change the delivery system. So we're not cutting you open from stem to stern and sew that piece of Dacron in. We're just going to put a couple of little ports in your abdomen, but we will give you the same durability. That's the concept. Okay, it's not there yet, but that's kind of the idea. Anyway, how do we all become you, Charo? I mean, what's the process by which we all become skilled robotic surgeons when we're starting from ground zero for most of us?
So there is a definite difference in, like, for example, if you look at trainees coming into practice now, the integrated vascular residents will not have as much robotics experience as a general surgery resident will. In order to get trained as a robotic vascular surgeon, there are certain hoops that we have to follow through. One being the initial certification from Intuitive saying that, yes, you are certified to operate on these robotic platforms. And that comes either in residency training because of exposure to cases, which all general surgery residents will have, or by doing more robotic cases, simulation, etc. after you finish training, which is the hardest part to do, which I had to do myself. Once you get that certification, then the next hoop is the privileging and credentialing at the hospital. And that requires a lot of buy-in from the robotic committee at the hospital, your hires up in your practice, who can enable you. And luckily, we've had you, Dr. Lumsden, and Dr. Miles, who's our vice chair of urology and our director of robotics in the hospital. So it requires some training, some buy-in, so then we can become vascular robotic surgeons. We will never be trained by the company as of today because it's off-label for any of the robotic companies to have vascular as their specialty. But this is where then we have to put a foot forward and say, okay, we should have our own investigational device exemption or IDE set up so that these companies can buy into doing vascular procedures safely and then eventually get FDA clearance with data showing this is safe and effective as an open procedure. I will say that doing robotic surgery requires us to be open surgeons first, because when I spoke to thoracic surgeons and urologists saying that, okay, I have trained in general surgery, I know some laparoscopy, so I should probably be okay at robotics. And they said, no, this is not laparoscopy. This is actually open surgery with an extension of your hands inside the belly, because those instruments can rotate up to 180 to 270 degrees of movement. So essentially, it's an extension of your own hands inside the belly, doing work at a 10 times magnified level with instruments that can control, I would say, red blood cells crossing across the screen. You can hold on to them and stop them. It's so precise. So being a good open surgeon is also a prerequisite for becoming a good robotic surgeon.
So for the purpose of the audience listening that may have no experience, what exactly the robot does that your hand by itself wouldn't be able to do? You just mentioned something very important, very precision of very small distances. Can you expand a little bit more on that? I mean, if I'm a surgeon listening to you, I want to know, should I get into this? Exactly what is it that the robot does that my hands wouldn't be able to do well?
Okay, great question. And I'll give you two concepts. One is, what does the robot do for me as a surgeon? And then I'll give you an example of a case where it helps me much more than an open surgical procedure. So essentially, the robot has a big a stand, essentially, which has 4 arms that come in from above. They are docked onto ports, which are cylinders through which instruments go in. Those instruments are connected to a big computer box, so to speak. And that computer box is connected to a console. Essentially, it's a place where I sit. I look into a scope, which has 2 cameras that are slightly offset. So it gives us a 3D picture of what's inside the belly. So there is a depth perception. And then there are joysticks, I would say, or holders that my fingers go into. That they translate my movement at the finger level into the instrument that's in the body. The energy control, or we say the control for stopping bleeding or to cut or to divide a blood vessel or to cut a blood vessel or tissue, comes from specialized instrumentation, which are also controlled by the same joysticks that are in my hand. So it essentially translates my movements into the patient. It takes away the tremor that I may have at the end of a long day trying to do the 5th case of the day. It takes away that inefficiency that I might have. And the example where magnification and precision helps is a great case where the aorta is the big blood vessel that comes from the chest into the belly, gives off a branch called a celiac artery that supplies the stomach, the spleen, and the liver. That artery straddles just under the two leaves of the diaphragm that support the chest and the belly. And those diaphragm muscles, they pinch the artery again and again when we breathe up and down. It's not so much the blood flow of the artery, but there are nerves surrounding the artery that get pinched and they cause pain. And we call it median arcuate ligament syndrome. That procedure can be done open and can be done with a laparoscope or can be done with a robot. But when we do it open, the actual structure in relation to the abdomen, as you were talking about a CT scan, and we render the images so that we can see what level of the skin corresponds to what level is deep inside. That artery corresponds to just above the breast end of the breastbone, almost inside the chest, looking from the belly on the inside. So I'm looking upstream and down into at the back. So that is a very weird angle to operate on is an open procedure. But with the laparoscope, the camera goes about 2 centimeters or 3 centimeters away from the object that we are trying to operate on, and it's magnified about 7.5 times. So the precision of dissection, the precision of visualization is superbly superior to an open procedure.
You did a great job explaining it. Yeah, I can see it.
Can I show you one other example?
Yeah.
So a lot of general surgery programs are bypassing laparoscopic surgery now because it's much more difficult, okay? If this is a patient's abdomen and you put a scope in their abdomen, now we're looking down here, laparoscopically, the way you move the end of the instrument to the patient's right is you move your hands
you have to go the opposite way.
You have to go in the opposite direction.
Opposite way.
What this machine does is really translates your hand movements. It's called intuitive because there's a little wrist on the bottom end of it. Yeah. And so the reason they call it intuitive because it's not as big a real learning curve to do it. It's very smart, actually. All right, we're probably running a little late. Let's get this last question and back to you, Stuart.
Okay, so I'm delighted to have patching in from sunny, warm Toronto in Ontario, Canada. We have Dr. Ali Tavayeli. He put a wonderful comprehensive paper together on robotic systems and cardiovascular interventions, evolving platforms and the path forward. So it really covers the entire gauntlet of all the cardiovascular technologies and methodologies out there for robotics. So Ali, we'd love to learn a little bit more about that. I guess our first question is, what is the major change or improvement that you've actually seen in this field that really excites you?
First of all, thank you for having me. It's a pleasure to be here. About the technologies, as we were just chatting a bit, about the intuitive surgical system, I think we really have to appreciate why the intuitive surgical system was so successful. It enabled more and allowed us to achieve more with our hands than we were able to do typically with the conventional devices, laparoscopic tools. And I think that's a fundamental thing that, we have to pay attention to when it comes to the robotic endovascular catheter space. There has been a fair bit of development over the last 20, 30 years, but very little of that has been so successful or been adapted like the intuitive surgicals of the world. And I think so for me, any technology really that pushes us in that direction is attractive. So it's more than one. And I could talk about a few of those. But like, for example, obviously, like, who can ignore the potential of AI? Traditionally, when it came to robotics, we were controlling them with classical control techniques, as you may know. But now AI, as we see with humanoid robots and other robotic systems, has truly enabled us to overcome that fundamental limitation in modeling and controlling these systems. So I expect to see exponential growth and ability to control such robotic systems. Obviously, integration of imaging and other sensory information and forces and whatnot is going to be a fundamental factor in that process to essentially provide the robot with all the information that the clinician would have typically during the procedure. But AI truly does have the potential to integrate all of that information and allow, for the very least, for semi-automation or improved procedures. And there's also a lot of developments on the mechanical front to again, similar to the Da Vinci tool that we discussed, those were miniaturized design devices that allowed us to really miniaturize our arms and wrists and go inside the abdomen and do things that we wouldn't be able to do otherwise. There's a fair bit of mechanical development on that front to allow us to precisely control the tip of devices and manipulate them locally instead of proximally from outside. We've had already successes on that front with remote magnetic navigation, but now we're seeing mechanical solutions pop up. That's also very exciting. And also we're seeing developments or efforts to address some of the fundamental economic and procedural flow challenges. We've had a lot of challenges with very high cost for adoption or infrastructure for robotic systems. Now we're seeing miniaturized mobile platforms that are being developed, and also devices that accommodate the entire procedure, not just one catheter, multiple devices at the same time, and so forth, taking that holistic perspective.
No, those are very good points there, and you've kind of overlapped and hit on some of the other questions we've got for you, right? Mm-hmm. So as the CRC chair and systems and devices, cardiovascular interventions, I'm assuming you interact a lot and interface a lot with clinicians and hospitals who want to get into the robotic space. They come to you for advice, etc. So what is the most important factor to ensure successful implementation of cardiovascular robotics?
Yes, a great question. And I guess it's difficult to just extract one specific factor. I think, but most importantly, my perspective is the added value. What are you adding in terms of the value to the procedure that is justifiable at the cost? Obviously, we know, X-ray is a problem. One of the initial pushes for remote catheter navigation systems was to distance the operator. And this is sort of what I did even for my PhD thesis, more than 10, 15 years ago. So we wanted to distance the clinician from the ionizing X-ray, and maybe there wasn't much awareness around that now, but nowadays, there was a very good documentary, Scattered Denial, as you may have seen it. So that was it's a very good documentary that talks about the challenges that this causes and all the higher incidence of tumors and all the other complications that this radiation creates. So that was the main driver for having telerobotics and allowing the clinician to operate from a distance. But I would say that's not enough. We need more and above that. Ethically, obviously, that's justifiable. But from a buyer's perspective, or the reimbursement, or the institution to justify the cost, we need to add more value than what we would do. So I don't think it's just about the cost, for example, because we have seen, for example, robotic systems that were super expensive, like the stereotaxis system, but it was actually adopted more than the competition mechanical solutions like the Hansen and whatnot. And I think a big part of that was because the stereotaxis system, although it still survives and has a bunch of other practical, larger scaling challenges, but has done a better job in commercial success because it allows a clinician to do more again. You were able to achieve stuff that you wouldn't be able to do with those mechanical solutions. So although it was a much higher price, it still succeeded. So it's not just the price factor is not the only factor, I think. Yeah. So I think, those are the main.
So my last point is, you may have heard, but literally yesterday, there's a Lithuanian company called Setonte, and they have a telerobotic catheter system, and they've done the first ever transatlantic feasibility study. So they were based in East Coast America, and they performed a procedure on someone in Dundee in Scotland. Now, we actually literally had those guys in here in the studio just over a year ago. So it seems to me that the breakthroughs and bottlenecks might not necessarily be based in the technology. It might be based more in maybe the legal aspects of operating telerobotically, or maybe more administrative. Can you maybe just quickly comment on that? What are those bottlenecks?
Yeah, absolutely. I've seen this teleoperation even before that. It's been proven with the Intuitive and then with other robotic systems as well. So I think feasibility technology-wise, it's out there, and you're now able to experience this. Let's say even on a video gaming platform, you can play real time at folks across the world with a similar bandwidth of data being communicated. So it's more about what happens if things go wrong. If this patient, if there's for whatever reason there's a rupture, what do? You need to do an open surgery. Who's going to be doing it? And if you need an expert there to begin with, might as well let them do the procedure. So who's going to be liable if something breaks down? Is it the technician? Is it the company internet service provider? Is it the other person across the world? So those are all big problems that we have to address. And I think, as you said, like the regulatory burden seems to be the most important burden. And I think ideally the robotic solutions should be comprehensive to think about the entire procedure within the hospital setting, not one unique aspect of it. It's not just about manipulating one catheter. It's about everything else that could happen adjacent and as part of that procedure as well, with the staff, with the support, with anesthesia, with all the devices that are supported and so forth.
Coming back to more mundane things like doing it here in the good old USA. As hospitals get more and more into robotics, they have to invest in equipment, and they have to invest in training of people, sending people for training or hiring people with the expertise. What's the current reimbursement for adding robotics to a surgical procedure? Is there any change? Anything?
So,
you get paid more, or what? What's happening there?
Yeah, I think it depends. It depends on some of these procedures. You have to apply for new codes, because the robotics not necessarily covered. That's also obviously a challenge, especially like if you're not able to have your disposables at a justifiable cost, and you can. I mean, obviously there's a massive infrastructure cost that the hospital has to carry. That's not going to be reimbursed. There has to be economic incentives for the institution to do that. But if you can't bear the weight of the disposables as part of existing CPT codes, then obviously then you have to apply for a new code, and that can be a very lengthy, challenging procedure, as you well know.
So since you are the medical director of the heart center, you perhaps have a little bit of experience. What's happening in our place with the reimbursement for any of this? Is it?
Well, it's more costly. These machines cost $2.5 million.
Yeah.
And that's why we have a robotics committee who parse them out. So occasionally you can get extra reimbursement. Sometimes it's reimbursed as an open code. But the other place you do make money is shortened hospital stays, And that's a pretty powerful driver, because if, let's say it was an open aneurysm repair, you normally get DRG 6-7 days, and you get that down to 3 days. You save on that DRG. Right. But you double that because you get another patient in that bed. Yeah. And so that's one of the reasons that everybody pushes so much on the length of stay, is that you get the next paying patient in the same unit, the bed, and that's where these robotics companies make an argument. I'd say most hospital administrations prefer that robots went away, but they're so dependent upon the clinicians to be able to use these. Now, one of the challenges is more competition in the marketplace. Right now, Intuitive have a monopoly. They don't negotiate. J&J are about to release a new robot. We kept therapy. It's always towards the end of the year. So I hope it's towards the end of this year, not towards the end of next year. But these are all big time issues that we're dealing with. Now, let me pick up on the catheter robotics, is that because you talked about clinical need. What's going to drive driving catheter robotics forward is stroke, okay? Putting a catheter up in somebody's head and sucking out a piece of clot is the single most cost-effective intervention in medicine. As you know, strokes don't kill you. They just maim you for the next 10 years. Yep. And so it's why all these stroke centers have been set up that, you come in here, just like pioneered by cardiology. If you'd ever told me that you could go from door to balloon time in 90 minutes, that's impossible. And yet that's been engineered across the United States. Same thing that's happened with strokes. But the problem is there's a lot of you guys, a lot of cardiologists, and you cover the country. There is not the same number of stroke interventionalists. In fact, I think it's only like 600 or 700 in the entire country. And so you don't have to go far away from Houston. You ain't getting that. Right. And so the investment that's taking place around robots, a lot of it is remote stroke intervention, because it is cost effective. Therefore, it's worthwhile investing money in trying to build these platforms. And so the idea would be, could you have the people in the stroke center here running these robots? Now, somebody's got to get the catheter in, but that could be a vascular surgeon, it could be a general surgeon, it could be a cardiologist, it could be a radiologist, and then let the stroke guys basically take over. So you revascularize and then make a decision whether you're going to ship the patient. So that is really helping drive these catheter robotics forward at the moment.
So currently, as we speak, do you have any estimate of the penetration of this technology in the US right now? In terms, would you say that most of the major cardiovascular centers in the country are already in some form working with robotics, or even there you still don't have a full penetration?
So the weird thing was that the intuitive surgical robot was designed for cardiac surgery. In fact, our Randy Wolf was in Germany when they were working on this. Mm-hmm. They couldn't do it. A urologist happened to come by, watch them, say, hey, maybe I should try doing the prostate. That saved that company. Otherwise, it probably would have gone belly up. And so it pivoted into prostatectomy. And then it's expanded from there into GYN, general surgery. Finally, we got vascular surgery involved, but cardiac surgeons. So, for example, mitral valve repair, a lot of places are doing it, with the robot at the moment. We haven't, because we've got people doing minimally invasive mitral valve repair. Now they actually need the robot. So, yes, it's expanding in terms of vascular robotics, the kind of stuff that Chad was doing. No, we are easily the lead center in the United States in doing this.
So the penetration still is relatively small then,
yep.
If we go across the country.
Yep.
And certainly in smaller hospital, you could say probably zero.
Yep.
Okay. So now, looking at the future, what do you foresee 5-10 years? Usually in medicine, we talk about 5 years intervals. What do you either foresee or maybe hope for that will happen to this technology?
You want to go?
Yeah. It's a really exciting time to be in this space, to be frank. I mean, I don't think anyone's even comprehensively knows what's going to happen with AI. Seriously, I mean, this is going to be a complete game changer. But that aside,
Sure.
What really excites me is there's a lot more robotic systems coming to market now. I mean, one example is the Samani system by MMI. That's a micro surgery system for submillimeter anastomosis. They've got FDA approval for certain indications. They're growing, okay? There was the Centonti system I mentioned earlier. You've got Intuitive, which are still out there. So as you know, the more systems that come on the market is going to drive competition, and hopefully that will drive down the cost, increase quality, so a real big benefit for the patients, etc. Then you start layering in the AI component. I hate saying this, but a lot of people do come up to me, because I'm not a surgeon, I'm not an MD. They say, hey, Stuart, do you really think AI is going to allow for autonomous surgery? And my answer straight away is yes. And I actually think that is going to happen at some point. How widespread and how well adopted that's going to be, that will be for, I guess, humanity, for the people to decide. But the technology is there, and we're just at the very beginning of it.
We're coming close to the end of the hour, so
Yeah.
there's one question I wanted to finish up with, because all throughout this webcast, you guys have been mentioning companies. So there's no question that the progress of this technology and application is going to require the partnership of physicians, academicians, people like you who are a PhD, and companies. Mm-hmm. And that's always a little bit of a gray area to navigate. So Alan, how do you see that going? Could there be some issues that we have to address, given the amount of partnership that was going to happen between academic institutions and industry?
Oh, no question. There's going to be issues around it. But I've worked with industry all my life. There's got to be some firewalls to some extent. But they can't do it without you and I, okay? The world is probably replete with devices that have been made without clinical input, and they go, it's a great device, worthless, can't use it at all. And so I really bristle a little bit about the barriers that are placed between industry and us. And I always talk about, we're one of the biggest Siemens installs in the world. And I always say that the relationship changed when we took our administration to Germany, and they heard scientists and engineers from the company talking about science, because you got to realize this is where we have to help bridge that gap. Our administration's contact with a company is, Dr. Lumsden wants you to buy this device. What's that device cost? It costs a fortune. I don't want to do it. And so they don't see the incredible amount of engineering activity, science below that level. And I think that's where we need to help. So for example, we took our administration to Boston Scientific. They saw these assembly lines and the way they ran quality and the way they empowered the people on these assembly lines to give them feedback about how they can continue to make it better. And I think we need to continue to encourage that. It's a big mistake to firewall this to the point that we're not giving input into industry and vice versa, actually.
Well, thank you very much. And I think we're getting close to the conclusion of our hour. I just want to encourage all the audience to read the journal because there's a lot more wonderful material that we weren't able to cover. And as you can see, although we did not discuss a particular disease, this was a very exciting webcast. And I think we are entering an era combining technology with AI that is going to be absolutely a game changer. So thank you very much for staying with us all this hour, and I hope you have